Hi, I'm Dr. Masters, and I practice at Austin Addiction Medicine Associates. This evening, my colleague, Liam Guthrie, who is an MD, PhD medical student, will also participate in the lecture because he answered the questions that were submitted in writing by the Stevens Ministry group. And I hope that you will forgive my ineptitude when it comes to the tech thing. I'm trying to get my slides to go here. There we go. And so, excuse me, the title of tonight's presentation is a primer on addiction. And what I'm going to do, I'm having trouble getting this to advance the slide.
Sorry.
Okay. All right.
I went too far. Now I won't again. It's right there. Right there. I'll do it.
Okay.
How's that?
Okay. So the title of tonight's presentation is a primer on addiction. And before we get into the presentation, I'm going to give you an outline of the outline, so to speak. I'm going to introduce the topic by talking a little bit about the societal and cultural aspects that impinge upon the disease of addiction, particularly the stigma associated with it. Then we're going to get right into the heavy hitters in addiction, alcohol, opioids, marijuana. Then there'll be some comments on the effects on the family. And then finally, in about a half hour, we will conclude with some concluding remarks, and then we'll move right into the typewritten questions that you submitted. My favorite definition of addiction is from John Bradshaw, who said that an addiction is a pathologic relationship to a mood-altering substance, behavior, emotion, or relationship that results in life-damaging consequences. Normal people, which I like to refer to as neurotypical, are individuals who don't become addicts. So for instance, with respect to alcohol, 85% of the American population drinks, 15% of men are alcoholic, 10% of women are alcoholic. But the vast majority of people who consume alcohol are neurotypical and therefore not alcoholic. I'm often I lecture to the medical students at Texas A&M School of Medicine in Round Rock on the topic of addiction. And I tell them that if I were going to synthesize an addict in the laboratory, I would need 5 things: genetic predisposition, dysfunctional family of origin, early childhood physical or sexual abuse, concurrent psychiatric disorder, and access to alcohol or drugs. That's the recipe. And in my experience, if you have 4 out of 5, and certainly if you have 5 out of 5, it's uncommon, bordering on rare, that those individuals don't become addict or alcoholic. The disease of addiction is characterized by signs and symptoms, but those signs and symptoms tend to be antisocial in nature. So take, for instance, pneumonia. Pneumonia is characterized by cough, fever, shortness of breath, and chest pain. Addiction, however, is characterized by lying, cheating, stealing, manipulating, and committing criminal acts to get the money to do the dope or to buy the booze. So there's a certain amount of stigma arises from the antisocial nature of the symptoms attendant to the disease. But the underlying societal stereotypes that, addiction is a weakness of character and inability to deal with life, a case of chronic limpet or a moral failing, nothing could be further than the truth. But when you have that type of stigma attached to a diagnosis, naturally, no one wants to identify with that. Therefore, you have denial. And as they say in recovery, denial stands for don't even know I am lying. So someone who is in denial doesn't even know that they're lying to themselves. We're going to talk now a little bit about the neurobiology of addiction and the science of addiction. This slide is it's as if someone took a plane and went right through the center of my head like this, and you're seeing what we call a sagittal section. Now, the brain, for the purposes of this discussion, is going to be divided into three major areas. There is the reptilian complex down in the pons and the medulla. This is a very primitive area of the brain. Tells your heart how often to beat, tells you when to breathe. Right above that is the mesolimbic system, also known as the emotional brain. This is where the disease of addiction resides, within the emotional brain. Above the emotional brain is the cortical brain. And it's the cortical brain that we think of when we think of other people, because that's where your ability to do math, language, moralize, philosophize, judge, criticize, your so-called willpower, that's up here in your cortical brain. But the disease of alcoholism and drug addiction is not in the cortical brain, it's down in the emotional brain. Why do we have an emotional brain? We have an emotional brain because certain activities in life, like food, sex, exercise, drinking water when you're thirsty, when you do those activities, you release so-called pleasure chemicals within the emotional brain that tell you at an emotional, irrational, nonverbal level, keep doing this. It's essential to your survival. Notice how I said essential, not optional. Drugs of abuse like alcohol, cocaine, heroin, methamphetamine, pot, etc. These drugs all strongly, consistently, and reliably result in the release of these so-called pleasure chemicals, which in the addict tell them that this is essential to my survival. The key point, if you take away nothing else from this lecture tonight, the key point should be that addicts and alcoholics are wired differently, okay? They are predisposed genetically to developing a pathologic relationship to a mood-altering substance. And if you talk to enough addicts and alcoholics, what you find is the following general story. Ever since I was a small kid, I've never quite fit in. I've always felt that there was something not quite right about me. And then I'm out there in the universe like a jigsaw puzzle with a couple of pieces missing until I bump into that drug or drink of no choice. And those puzzle pieces are plugged in and I'm good to go. And I'm going to run with that until I hit the wall. And then I might hit the wall again and again and again. So that's key. What the neurobiology tells us is that addicts and alcoholics suffer from having a hijacked mesolimbic system. Their emotional brain has been hijacked by alcohol and drugs. The key difference between an alcoholic and a normal temperate drinker is that in the setting of normal temperate drinking, the phenomenon of craving is unknown. But if you give an alcoholic a drink and he takes it, it will trip a switch in his brain and he will crave more alcohol. So one drink is too many and 1,000 is not enough. Well, naturally, the response would be, well, why don't they just quit? Okay, well, let's look at the neurobiology once again. If it's just a matter of choice, why aren't they able to do that? Well, getting back to our diagram here, the reptilian brain is the most primitive area. And the brain is hierarchical in nature. The more primitive the area of the brain, the more power it has. So the reptilian brain can override the emotional brain, and the emotional brain can and does override the cortical brain. What would be an example of this? When my youngest son, Kevin, was 8 years old, he went trick-or-treating. On November 1st, he's got a huge sack of candy. He's eating the candy, eating the candy, eating the candy. Finally, I said, Kevin, you're gonna get sick. And I took the candy away from him. What happened? He had an emotional reaction. He got angry. And it percolated up to the cortex, and the plan came out as follows. Daddy, if you don't give me that candy, I'm gonna hold my breath until I die. So what do you think I told him? Go ahead. Because I knew that the reptilian complex would override his angry response. It would override his well-articulated plan, and he would breathe again. This is the dilemma faced by the alcoholic or the drug addict. They have a hijacked emotional brain. And as you will recall, willpower is a cortical function, but the cortex is not as strong as the emotional brain. So what happens is the addiction persists. The only thing that we've ever found that reliably results in sobriety, one 24-hour period at a time, at least with respect to alcoholism, is a spiritual awakening. And how does that occur? It occurs through the 12 steps of Alcoholics Anonymous, but more on that later. Let's take a closer look right now at the so-called septal nuclei, or the pleasure centers in the emotional brain. We have two pleasure centers, the ventral tegmental area and the nucleus accumbens. And the nucleus accumbens is mainly attained to uppers, like amphetamines, cocaine, etc. And the ventral tegmental area is mainly attuned to downers, like alcohol, barbiturates, or benzodiazepines, drugs like Xanax. There's only two drugs that stimulate both pleasure centers. One of them is opioids. Opioids is one of the worst possible things that you can be addicted to because it's the hardest thing to kick. The other thing is cannabis. Now, no one has ever died from an overdose of cannabis alone, okay? And there is no withdrawal syndrome related to cannabis per se, but plenty of people have died from opioids. And there is a very severe withdrawal syndrome that occurs when you quit using opioids. So we're going to move on and talk now a little bit about alcohol. So as I said, alcoholism, I've already talked a little bit about craving and how that's a key component of the alcoholic presentation. But basically, alcoholism has been with us ever since man crushed grapes. And of the 85% of Americans who drink alcohol, 15% of men are alcohol dependent, 10% of women are alcohol dependent. Only 5% of alcoholics are Skid Row alcoholics. 95% of alcoholics are what you would call functional alcoholics. They have jobs, they have families, they go to work, they pay taxes. 50% of the alcoholics right now are in their 20s. They will not present for treatment until they're in their mid to late 40s or early 50s. By the time they have lost jobs, cars, their freedom, their marriage, et cetera, et cetera. Only about 10% of alcoholics will ever come to treatment. Of the 10% that come to treatment, 50% are gone from AA within 3 months, and they go on to insanity, incarceration, or death. The other 50% get sober one day at a time, provided they're willing to do some simple things. Sobriety in Alcoholics Anonymous is abstinence-based, and it's a byproduct of a spiritual awakening. The 12 steps are based on first-century Christian principles of complete and total reliance on God, confession, restitution, and helping others. The program itself was the brainchild of two alcoholics. Bill Wilson was the primary author of the big book of Alcoholics Anonymous, and he sort of guided the fellowship, so to speak, early on. And Dr. Bob Smith, who was an alcoholic colon and rectal surgeon from Akron, Ohio. Wilson based a lot of his ideas around principles that he obtained from the Oxford group, which was a Christian group studying these first-century Christian principles. We do have some medications that are beneficial. Naltrexone, an opiate blocker, can reduce craving. So if I give you naltrexone to reduce craving for alcohol, in 1/3 of patients, it will completely suppress craving. In the second third, it will partially suppress craving. And in the final third, it will do nothing. Camprol is another medication which is used for craving, and it operates on a different neurotransmitter system called the glutamate system. And I don't tend to use it because it's 6 tablets a day. That's really cumbersome. Now we're going to move on to discussing opioids. And this is a title from an editorial in the New England Journal a few years back: "A Flood of Opioids and a Rising Tide of Death." I think what this curve shows is total US drug deaths. I would tell you that right now, the #1 cause of accidental death in America today is drug overdose. And those drug overdoses are usually due to opioids or the combination of opioids plus benzodiazepines or opioids plus alcohol. So the latest, these are not the latest figures. This is from 2016. The latest in 1999, we had about 18,000 overdose deaths. Then the pain movement got underway, promoted by Purdue Pharma and some physicians and some distributors of pain medication. And we began to see increasing overdose deaths. And currently, the latest figures that I've heard is 93,000. Now, there's an important principle that's associated with the pandemic, and it is this: if you want to make any disease worse, I don't care if it's emotional, spiritual, mental, or physical, isolate the patient, and you will make it worse. And pandemic isolation has been a problem for everyone, but especially for the addict alcoholic population. And alcohol sales soared during during the pandemic. I have a patient who's a wine dealer, and well, that's another story. Anyway, yeah, they're doing great. Yeah. And this graph from Dr. Volkov at the National Institutes of Drug Abuse just shows the progression as the number of kilograms of opioids sold per 10,000 people increases from 1999 through 2010. So do deaths due to opioid overdose, and so do admissions to treatment for opioid dependence. How did all of this start? Well, it started with the pain movement. In the late 1980s, early 1990s, the Institute of Medicine published some papers indicating that primary care physicians, internists, family practice, etc., were not adequately treating pain due to end-stage cancer. We needed to be more liberal with our narcotic prescribing. Well, balance is not something that characterizes American society. Balance is that brief moment in time where the pendulum swings from one extreme to another. So we start over on this extreme with, hey, we're not giving end-stage cancer patients enough morphine because we're afraid they'll get addicted, swinging all the way over to, oh, now we're giving OxyContin for osteoarthritis and fibromyalgia. So that's what happened in the course of this pain movement. And of course, there was a lot of money to be made and a lot of profit incentive. And so Purdue Pharma, the makers of OxyContin, and large distributors like McKesson got rich off of this. But that's kind of come home to roost now because they've been the subject of numerous class action lawsuits and individual lawsuits. As Congress has recognized the severity of the opioid overdose epidemic, they have turned off the faucet, so to speak. And when you do that, you haven't done anything to treat the addiction. Now people have to go underground. So there's this tremendous move towards heroin. And what is really killing people left and right currently is fentanyl. So this bootleg OxyContin that we see on the street right now is largely fentanyl. And fentanyl is about, okay, so just to give you an idea, just a little primer on heroin. I spent like 6 years being the medical director of maintenance and recovery services, which is a methadone clinic. And so black tar heroin looks like a little ball of black tar. Back then, the going rate in Austin is $100 a gram. In San Antonio, it's 80. If you buy in bulk, you get a volume discount. The situation is that 1 milligram of heroin equals 1 milligram of morphine. Fentanyl is 50 to 100 times stronger than morphine. So 1 milligram of fentanyl is equal to 50 or 100 milligrams of morphine or heroin. And that's why you're seeing all these overdoses. And on top of that, not only am I seeing overdoses, but I'm also seeing people who are coming in who have, I'm giving them Suboxone for the management of their opioid dependence. And they're coming in having slipped off the Suboxone and onto the fentanyl. And what happens? Well, now we have difficulty getting them back on Suboxone, and I can talk about that later. But it has to do with some long-acting metabolites of fentanyl. At any rate, the key thing to understand is that short-term detox with opioids doesn't work. There's an 85 to 95% relapse rate. And you have to understand that opioids and heroin is a different animal from alcoholism, okay? The treatment of choice for alcoholism is we detox you with a benzodiazepine. We give you a big book, we send you to meetings, and you work the steps, you get a sponsor, you have a spiritual awakening, and you are relieved of the obsession and compulsion to drink alcohol. Not so with opioids. The problem with opioids is craving and dope sickness, okay? And we have to interrupt the cycle of craving and dope sickness. And the most effective means of doing that is by methadone and Suboxone. And Suboxone is simply son of methadone. It's licensed for use in physicians' outpatient offices. It's a little bit safer to use than methadone is. But they essentially do the same thing. They eliminate drug craving. They eliminate dope sickness. And if you do dope, and I have you on the right dose, you do not get high because your receptors are blocked. So you just wasted your money. So what does the structure of a methadone clinic look like? When you look at a methadone clinic, 50% of the people coming into a methadone clinic are still active drug addicts. They are just using methadone as a backstop until they can get more heroin, or they're combining their methadone with other drugs to get a boost. The other 50% are evenly divided into 25% of the total will eventually wean completely off of methadone and remain sober. The other 25% of the total will take methadone, perhaps lifelong. They'll never do anything harder than caffeine or nicotine. They will send kids to college, pay taxes, and lead average American lives. Why do we give people methadone or Suboxone? One reason and one reason only: save lives. Death rates are instructive. If you are a frontline combat soldier in Vietnam, your chance of dying is 3% per year. Smoke a pack a day for 20 years, 1% per year. Alcoholic, 0.5% per year. Shoot heroin or do other opioids, 7.2% per year. You are 2.5 times more likely to die from shooting heroin than you are from going to war. When you come into a methadone clinic or into my outpatient office for Suboxone, I lower your death rate from 7.2% per year down to 1.4% per year. Is 12-step recovery contraindicated in opioid dependence? The answer is no. I love 12-step recovery. I think it's terrific. It's just a lousy tool in the initial intervention with someone who is addicted to opioids, because opioids is a different animal than alcoholism is, okay? The situation is the Suboxone and methadone that I prescribe, they do what they are designed to do. They eliminate drug craving, they eliminate dope sickness. If I got you on the right dose and you shoot dope, you don't get high. But they don't do anything about the underlying emotional, spiritual, mental reasons that you picked up dope to begin with. For that, you really need a 12-step program. But if you think the stigma associated with heroin and alcohol and all these other things is just limited to lay people, there's plenty of stigma out there in the sober recovering community. I tell my patients who are interested in 12-step recovery, who are doing Suboxone, don't ever go in to an AA meeting and say in the open forum of the meeting that you're taking Suboxone, because that would be like stepping into the prize ring and leading with the chin. Somebody's going to knock you out, okay? You're going to get one of these old timers come up to you after the meeting, tell you you're not sober and you need to quit that medication and blah, blah, blah. And nothing could be more destructive than that. At any rate, the situation is, I tell them, look, when you go to AA, we tell you 5 things, okay? 90 and 90. 90 meetings, 90 days. Get a sponsor. That's someone who has 12 months of sobriety, has worked all 12 steps, and is going to guide you through the step work. Hit your knees in the morning and ask the God or higher power of your understanding to keep you sober. If you remain sober, thank that power at night. Don't drink or use mood-altering drugs between meetings, and read the first 164 pages of the big book of Alcoholics Anonymous. You know, when alcoholics do those things, they get sober, provided that they are constitutionally capable of being honest with themselves. This is a program that requires rigorous honesty. But you know, when you are shopping for a sponsor and you're taking Suboxone, you got to be careful, because you don't want to be out and out rejected. Because I've seen this over and over and over again. I tell my patient on Suboxone, go to 12-step meetings, get a sponsor, do all this, you know. They go out and they ask someone, they find someone they like, they can relate, their story is similar, they think it's going to be terrific. Ask him to be a sponsor. Sure, I'll be your sponsor. Then the sponsor finds out he's taken Suboxone and says, I can't sponsor you because you're probably getting high from this stuff. Oh, nothing is more devastating than that. It's just, you know, it just knocks all the wind out of their sails. And so basically what I tell them is, hey, when you go out there, vet your sponsor. You find someone you think is going to be a good fit, take that person out to coffee and say to them, well, you know, there's this opioid overdose epidemic and the doctors are recommending Suboxone and methadone. What's your opinion? And if he pipes up with, oh, those are tools of the devil, well, you don't want that guy as your sponsor. Believe me, I had a lot of those same biases when I came into this. And the thing that changed my mind about this was a 25-year-old woman who was I'm like garden variety AA, you know, I'm just steeped in it, okay? And so I'm learning rehab and everything. And I'm working in the rehab. This lady comes in, she's 25 years old. She's working as a medical assistant at a large hospital here in town. She's spending $100 a day shooting a gram of heroin a day. She comes in, she says, Dr. Masters, I don't want methadone. I don't want Suboxone. I want to get sober and work a 12-step program, you know. And I was just like, hallelujah, you know. I'm totally down with that because doctors love tough people, you know. 48 hours later, she climbed a 13-foot high spiked iron rail fence. She went out and she shot heroin, but then she came back. Now, I'd had plenty of people elope from treatment, leave from treatment against medical advice. I never had one come back. She came back because she just had to have relief from that craving. I put her on Suboxone and discharged her 5 days later, and she was stable. I became a believer at that point. So even if you're ignorant of the science, which at the time I was, your experience can cause you to arrive at a different conclusion. Now we're going to move on to pot. Oh my goodness. You know, the situation is that we live in Austin, Texas, where pot is treated like a condiment. You have your mustard, your ketchup, and your pot, okay? And people treat it like it is no big deal. Well, let me tell you something. It's no big deal for 90% of people. But for the 10%, which it's a big deal, it's a very big deal, all right? First of all, it's not an innocuous drug. It worsens depression, bipolar, anxiety, and if you're predisposed to schizophrenia, it hastens the onset of it. Also, if you're a teeny bopper, 13, 14, 15, and you're smoking dope on a daily basis, guess what? You're losing IQ points, okay? And as far as this amotivational syndrome goes, it's real, okay? What are the characteristics of a pot addict? Smokes daily, smokes even when alone, does the wake and bake, wakes up, gets baked, smokes even when they know they could become paranoid. These are people who function stoned all day long. And this is not the kind of pot that you guys were smoking in the 60s and 70s and 80s, okay? Back then, if you could get 8% THC, you were doing great. This stuff is 24 to 26% THC. That's 3 times stronger than anything that you smoke. And they now have something called dab, also known as shatter or glass, and it is 92 to 98% THC. And they are getting this stuff from the surrounding states where it's legal and bringing it in. There's no withdrawal syndrome associated with marijuana and no deaths due to overdose. That's true. But about 10% of the people who use it become addicts. And I can tell you from my experience that it is very common for people who are bipolar to present stating that they're on no medication, but they smoke pot at night so they can fall asleep. You know, that's extremely, extremely common. But the cannabinoid receptors in the brain, which are activated by the active ingredients in marijuana, those are ubiquitous. They are everywhere. And everything that I'm trying to do with antidepressants and mood stabilizers is reversed by pot. So there are psychiatrists in this town who will not treat a patient for depression if they know that they're smoking pot. So you know, for 90% of people, it's a recreational drug, no big deal. What about the effects on the family? Well, I forgot to mention, how do we make the diagnosis of alcoholism or addiction? We make the diagnosis of alcoholism or addiction based on your drinking or drugging intersects with trouble. And trouble comes in one of 6 varieties: romance, finance, health, family, work, or the legal system. You got trouble in any of those areas, then you've got a problem with drugs or alcohol. And as the addiction worsens, the non-drinking or non-drugging spouse begins to take on more and more responsibility within the family. This person becomes more and more isolated because of the disease of her spouse. You know, if someone is drinking out of control every day and you cannot predict what the behavior is going to be, you're not going to be inviting people over for social occasions. Kids are not going to come over and spend the night if dad or mom is uncontrollably intoxicated. Depression, anxiety, chronic headaches, stomach aches, irritable bowel syndrome, and nervous tics can develop. And in those people who are, you know, codependent or, you know, involved with alcoholics or drug addicts, they need to look to their own health and safety. But most of the time, they're concerned with trying to rescue the addict or the alcoholic. And I think that one of the most important fellowships that you can join if you are experiencing that in your own family is Al-Anon. Al-Anon is a 12-step group based on the 12 steps of Alcoholics Anonymous, which is for friends and families of alcoholics and drug addicts. And it has 2 core concepts that it tries to convey. The first is detachment. And detachment is loving someone enough to allow them to learn from the consequences of their actions. And the operative word there is detach, meaning don't even try and change him or her. You're not going to be able to change them. If they're going to change, it's going to be because they spent a night in jail, or they're dead broke, or blah, 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 blah. Any one of a number of different things. Most of the time, we don't do interventions on alcoholics or addicts because the family does the intervention for us. So if you look at the population in an inpatient treatment, 80% of them were kicked through the door by one of four groups: the judge, the employer, the parents, or the spouse. The other 20% show up because they're sick and tired of being sick and tired. If you are having to live with the disease of alcoholism and drug addiction, you should probably reach out for help to Al-Anon. And if you're having difficulty with depression or other physical ailments, seek help from your primary care physician. I want to move on to the conclusion now. A few rules of thumb. This is not science, but it's my experience. Manics like uppers, like amphetamines and cocaine. Depressives like downers, like alcohol and benzodiazepines. And psychotics like pot or LSD. Concurrent psychiatric disorders are very, very common in what I do. It's 50% of the people that I see, 50% minimum, have a concurrent psychiatric disorder like anxiety, depression, bipolar, psychosis, ADHD, post-traumatic stress disorder. What are the four correlates of long-term sobriety? Constitutionally capable of being honest with yourself, goes to 12-step meetings, does a thorough step 5 followed by a thorough step 9. And if you have a concurrent psychiatric disorder, take non-addictive medications to manage it. Untreated psychiatric issues are a very common cause of relapse. And with that, I'm going to conclude. I'll take one or two questions, but then I want Liam Guthrie to launch into reading the answers to the questions that you all submitted. Yeah, are there any questions from the Zoom audience? Nothing? Take it away, Liam.
Hello, can you guys hear me?
Yeah.
Awesome. So I had a chance to review these 17 questions that were submitted. They were very excellent questions that really touch on some of the practical aspects of addiction medicine and addiction psychiatry, as well as things that pretty much all folks, in my opinion, should be aware of because of the prevalence of substance abuse and detrimental effects that it can have, not only on the addict, but on those who may be in the same household, friends, family, loved ones, etc. So the first question was, how does a counselor help a client admit they're drinking too much alcohol, and what advice could you give a person in such a situation? In medical school and primary care, what we're taught is a really quick evaluation tool called the PAGE questionnaire that was developed in the 1990s by Dr. John Ewing at National Institute of Health. PAGE stands for Cut, Annoyed, Guilt, and Eye-Open. And it's 4 questions, an affirmative or question. Each question is given 1 point. If someone has 2 or more positives, there is over a 90% likelihood that they have an underlying unhealthy relationship with alcohol, and most likely meet criteria with DSM-5 for alcohol use disorder. And those questions are: have you ever felt the need to cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about drinking? And then, have you ever felt you needed a drink first thing in the morning, or an eye-open, to steady your nerves or to get rid of a hangover? So the reason why we use this tool is that in primary care scenarios, clinicians who issues with liver function, with other health effects of alcohol. There's subtle hints that a person is consuming too much and may have an unhealthy relationship. However, that patient may be in denial and be completely oblivious to the impact that alcohol is having on them. So this CAGE questionnaire really serves as an initial screening tool. There are other screening tools. There's MAST, or the Michigan Alcohol Assessment Tool. There's Audit C, a number of other tools that are out there. But really, the CAGE questionnaire is, in my opinion, the strongest and best initial screening tool, and it's one that a lot of folks can understand and have to have 8 years of medical training in order to ask someone for questions. And most everyone should be able to answer in negative or all four. And then when you're dealing with a patient who is in denial, it's very difficult because ultimately, as Dr. Masters mentioned, if a person has not had a run-in with law enforcement, if they've not had a major health concern or interpersonal relationships, they are a quote-unquote functional alcoholic or a functional addict, getting them to advance to the point where they admit that they have a problem with a substance is very difficult. Often, until one of these major events happens, that kind of shocks their realization and gives them insight into the substance issue. It's very difficult to admit the problem. Okay, the second question is, how do you open up a dialogue with a loved one about addiction? So the Partnership in Addiction recommends that addiction only be discussed with patients when they are not under the influence of alcohol or drugs. Very important. One thing, if a patient is under the influence of alcohol or another intoxicant, there's a high likelihood they won't remember what you discussed. And another is that they don't have full control over their actions, may respond in an aggressive manner, or may tend to withdraw from the individual that are attempting to help them. It's best to try and have a two-way conversation that is non-judgmental and certainly not angry in tone. You want to emphasize that you, family and friends, and those who are attempting to help the patient, you're supportive, and that your main goal and reason is to help the patient. And then also keep expectations reasonable. There are a lot of television shows and reality TV programs out there that show this really big dramatic intervention, and then they'll cut to a few months later and the patient has made a remarkable recovery. That's usually not the case. Recovery is a lifelong process. It requires medical intervention. It requires the assistance of medicine specialists and psychiatrists. It involves 12-step programs and lifestyle changes. So folks need to be very patient and addict. And then, as mentioned before, if a patient is not ready to commit to recovery, there is very little that you can do as a family member to force them into recovery. They have to be willing to make, to ask for help and to change. Okay, the next question was, what resources are available for families of addicts? So there are multiple resources that are available. The best resources found online. There's the Substance Abuse and Mental Health Services Administration Helpline, found in the handout that I prepared. There's the Betty Ford Foundation. As Dr. Masters mentioned, there's Al-Anon, Nar-Anon, and other 12-step programs that are designed for families and friends of addicts. There's Families Anonymous. There's Smart Recovery, which is a secular alternative to Alcoholics Anonymous and Narcotics Anonymous, the more spiritually based 12-step programs. And then For those that unfortunately do pass on, there are grief recovery after a passing or grasp support network. So these are just a few of the most common and support programs that are available in the Austin metro area. But there really are a large number of services that are available, many at free or reduced charge, but for a lot of inpatient services, medical services, it's very difficult in the addict population, lack of insurance. And do you guys have any questions about the first three? Okay, I'm going to try and speed these up a little bit. So demographic trends in addiction in terms of gender, age, and income, and does it vary by which substance is used? I would say that addiction is a great equalizer amongst race, ethnicity, gender, age, and income levels. Certain groups do have genetic predispositions to certain types of substance use disorders, but this is a topic very controversial in psychology and in psychiatry. There are genetic predisposition that runs in certain races and ethnicities. For example, Caucasian Americans or whites and Native American groups have the highest incident of alcohol use disorder, whereas African Americans and Asian Americans have the lowest incidence of alcohol use disorder. Age-wise, younger Americans are more likely to engage in binge drinking and other unsafe forms of alcohol consumption, whereas the mean age of an alcohol use disorder diagnosis is 42 years of age. And then in terms of overall predisposing factors to substance use, by and large, the greatest contributor is genetic predisposition and exposure. Okay, what are the signs of drug or alcohol addiction? Signs are varied depending upon which substance is being used. They may be subtle and varied. You have folks who have quote unquote dual lives in which they don't overtly manifest the signs and symptoms of substance use early on, or they have a prolonged period in which they are functional addicts. In general, folks that have new health problems, including weight loss, gain, rashes, sores, needle tracts, bloodborne diseases such as hepatitis, HIV, or cough, be associated with substance abuse. Changes in behavior such as isolation, secretiveness, personality changes, apathy, aggression, intoxication, or changes in personal relationships with families and friends, work or school problems, tardiness, absence, poor performance, excuses, and then financial problems without an obvious cause due to chemical. Okay, moving
Well,
on. Yes.
Unfortunately, we'll have to stop now because we're reaching the 8 o'clock hour. I just want to emphasize that Liam has answered all these questions with references, and I'm going to leave a copy of that here. I also sent a copy of all of his answers, plus an excellent presentation that he did on alcohol use disorder. I've sent that to Anita, to her email, and so she can copy you all if you are interested in further information. I'm sorry that I ran over Liam. I kind of ran into territory, but I really appreciate all the fine efforts. At any rate,
I just wanted to address one last question real quick, and that was, is addiction really hereditary or is it due to exposure? Yes. So for alcohol use disorder, it's estimated that genetic contribution is upwards of 60%, and with the exception of cannabis, genetic markers and factors are in excess of 45% contribution. So that's sort of the most important. And these are not nebulous biomarkers. These are to the genes that we study the structure and interaction of these intoxicants, and as well as their effects. So if someone ever tells you that moral failing or the personality or character flaw. It is hardwired into the genetic code of these addicts.